Welcome back to the NextGen Pharmacist Masterclass. Today we are dismantling a massive challenge in preventive cardiology, statin therapy. Statins are the cornerstone for managing atherosclerotic cardiovascular disease, hypercholesterolemia, and acute coronary syndrome. But while the clinical indications are clear, patient response is radically variable. Every day, clinicians encounter a frustrating paradox. Two patients with identical cardiovascular risk factors receive the same standard dose of statin. One achieves optimal LDL cholesterol reduction with zero adverse events. The other develops debilitating statin-associated musculoskeletal symptoms, or SAMS, causing them to discontinue their life-saving medication. Why does this happen? The answer is written in their pharmacokinetic blueprint. To understand precision prescribing, we must anchor ourselves to the 2018 ACC/AHA cholesterol management guidelines. Clinical practice dictates identifying the four major statin benefit groups. First, secondary prevention in established ASCVD. Second, primary prevention in severe hypercholesterolemia with an LDL greater than or equal to 190 mg per deciliter. Third, patients with diabetes mellitus aged 40 to 75. And fourth, the general population with a 10-year ASCVD risk assessment. The ACC/AHA guidelines mandate matching a patient's risk to a specific statin intensity tier. High-intensity therapy aims for a 50% or greater reduction in LDL cholesterol using doses like atorvastatin 40 to 80 mg or rosuvastatin 20 to 40 mg. Moderate intensity aims for 30 to 50% reduction, while low intensity reduces LDL by less than 30%. But forcing these standard guidelines without checking a patient's genetic safety is exactly what triggers clinical toxicity. If you are finding this clinical breakdown valuable for your practice or your studies, hit that subscribe button right now. Leave a comment below letting me know, have you ever had to switch a patient's statin due to unexplained muscle pain? To master the pharmacogenomics, we must first categorize the statin family based on its physiochemical and intensity profiles. We have lipophilic statins like simvastatin, atorvastatin, lovastatin, fluvastatin, betavastatin. These pass readily through cellular membrane via passive diffusion, exposing peripheral tissue like skeletal muscle to higher relative concentrations if systemic clearance falls. And hydrophilic statins like rosuvastatin, pravastatin, highly polar. They rely almost completely on active carrier-mediated transport to cross the hepatocyte membrane, demonstrating lower passive distribution into non-hepatic tissues. To understand how genetic variation alters a drug's trajectory, let's revisit its molecular endpoint. Statins are competitive inhibitors of HMG-CoA reductase, the rate-limiting enzyme in the hepatic mevalonate pathway. By shutting down this internal synthesis plant, the liver's intracellular pool of cholesterol drops. The liver's adaptive survival response is what actually saves your patient's life. Detecting a critical shortage of cholesterol, the hepatocyte increases the transcription and surface expression of LDL receptors. These receptors act like biological vacuums, actively pulling atherogenic low-density lipoprotein cholesterol, LDL-C, out of systemic circulation. This dramatically clears plasma lipids and stabilizes arterial plaques. But here is the catch. HMG-CoA reductase is an intracellular enzyme. A statin floating in the hepatic blood sinusoid cannot do its job from the outside. It must cross the basolateral membrane. While lipophilic statins utilize partial passive diffusion, the primary efficient entry point for all statins is an active influx transporter known as OATP1B1. This OATP1B1 is encoded by the SLCO1B1 gene located on chromosome 12. Variations in this gene dictate exactly how many functional doorways are built. The most critical single nucleotide polymorphism, SNP, to remember is C.521TC. This single nucleotide swap alters the structure of the transporter protein, dropping its performance off a cliff. When examining SLCO1B1 star alleles, the core single nucleotide variations dictate distinct pharmacokinetic phenotypes. Star 1 allele, wild type, confers standard fully optimized OATP1B1 transporter function. Star 5 and star 15 alleles both carry the definitive C.521TC missense mutation, causing a profound loss of protein transport capacity. If a patient carries a loss of function allele, the statin is effectively locked out the liver. This causes a dual clinical failure. First, reduced hepatic efficacy. Less drug enters the target tissue to inhibit HMG-CoA reductase. Second, elevated systemic exposure. The unabsorbed drug backs up into the blood, exponentially increasing the area under the curve. This systemic overflow floods skeletal muscle tissue, directly inducing mitochondrial dysfunction, myalgia, and potentially life-threatening rhabdomyolysis. When statin blood levels spike due to poor clearance, the drug builds up in non-target peripheral tissues, leading to statin-associated muscle symptoms, or SAMS. While observational studies shows that up to 10 to 15% of patients complain of real-world muscle aches, rigorous double-blind randomized controlled trials prove that true. Pharmacologically induced myalgia occurs in only 1 to 5% of patients. The clinical spectrum ranges from benign to severe. Beyond mild myalgia, true myositis, which involves muscle symptoms combined with creatine kinase elevation, occurs in fewer than 0.1% of patients. Severe life-threatening rhabdomyolysis is exceptionally rare, appearing in less than 0.01% of cases. Beyond muscles, we observe an asymptomatic rise in liver transaminase ALT and AST in 0.5 to 2% of patients, which is highly dose dependent. We also see a tiny 0.2 to 1.2% absolute risk increase in new onset type 2 diabetes, concentrated primarily in patients with pre-existing metabolic syndrome. Now, let's translate theory into direct clinical practice by reviewing the precise evidence-based statin dosing recommendations based on the patient's SLCO1B1 functional status. We begin with our first chart, the SLCO1B1 decreased function genotype. As a reminder, our visual legend categorizes clinical actions into 3 distinct safety paths. Light gray indicates a standard starting dose. Dark gray warns us of increased systemic exposure risk. And black means it's time to reduce the dose or select an alternative statin entirely. Look at how the guidelines distribute risk across ACC, AHA statin intensities here. For high-intensity therapy, Rosuvastatin 20 mg remains in the safe, light gray zone with a low SAMS risk. However, as we step up to atorvastatin 40 mg or rosuvastatin 40 mg, we cross into the dark gray warning zone. Pushing a decreased functioner to atorvastatin 80 mg lands us squarely in the black box, meaning alternative therapies or lower doses are highly recommended to avoid myopathy. In the moderate intensity tier, standard choices like rosuvastatin 5 to 10 mg or atorvastatin 10 to 20 mg are perfectly safe. But notice what happens to the highly lipophilic options. Fluvastatin 40 to 80 mg and simvastatin 20 to 40 mg immediately shift into the high-risk black box, signaling clinicians to avoid them. Even under low-intensity prescribing, while fluvastatin and bravastatin are completely cleared in light gray, a standard dose of simvastatin 10 mg carries enough exposure risk to warrant a dark gray clinical alert. But what happens if the patient has two non-functional copies of the gene? Let's transition to our second chart, the SLC01B1 poor function genotype. Immediately, you will notice a dramatic visual shift. The safe light gray options shrink significantly, and the high-risk black boxes expand across all three intensity categories due to severely crippled drug clearance. Let's reevaluate our options for a poor transporter function genotype. Under high-intensity guidelines, only rosuvastatin 20 mg manages to hold onto a low SAMS risk profile. Atorvastatin at standard high-intensity doses of 40 to 80 mg and even high dose rosuvastatin 40 mg are now pushed directly into the black box. For these patients, high-dose lipophilic statins carry an unacceptably high risk of myopathy. Looking at moderate intensity options, low doses of atorvastatin, bravastatin, and rosuvastatin remain usable. However, the black box completely engulfs fluvastatin 40 to 80 mg and simvastatin 20 to 40 mg. For a poor functioner, moderate intensity simvastatin behaves like an overdose. Finally, check out the low intensity tier. Even at these minimal therapeutic doses, simvastatin 10 mg and fluvastatin 20 mg plunge straight into the black box. If your patient needs low intensity therapy and is a poor transporter, you must use options like fluvastatin 20 to 40 mg or bravastatin 10 to 20 mg instead. To round out our mastery of precision cardiology, we must acknowledge that SLC01B1 doesn't act completely alone. A comprehensive CPIC evaluation requires checking two secondary genetic pathways, ABCG2 and CYP2C9. These genes control the cellular efflux and phase 1 metabolism of specific statin molecules, acting as secondary safety valves. ABCG2 encodes an efflux pump that pushes drug out into the bile. The critical variant is C.421CA. Patients with decreased ABCG2 function cannot pump the drug out, causing an accumulation of rosuvastatin. This requires clinicians to cap rosuvastatin starting doses at lower thresholds. Concurrently, CYP2C9 is the primary enzyme responsible for breaking down fluvastatin. Individuals carrying loss of function STAR2 or STAR3 alleles are intermediate or poor metabolizers. Because their liver cannot clear the drug, fluvastatin levels spike, requiring standard dose reduction or alternative agent selection. If this masterclass elevated your clinical practice, hit that like button, subscribe to the channel, and drop your question below. Until next time, keep practicing precision medicine.